Sovereignty and human rights in public health policy governments carry the primary duty to protect the health of their people, and they also hold the sovereign right to set policy in line with domestic priorities and realities. These ideas are not in conflict. The right to health, recognized in international human rights law, is not a limit on national decision-making. It is a framework that supports strong, legitimate, and locally grounded public health action. Public health sovereignty is not isolation. It is the national capability to set policy goals, define standards, regulate markets, and allocate resources in ways that reflect local conditions, while still meeting human rights obligations and benefiting from international cooperation. The core recommendation is simple. The challenge is not choosing between sovereignty and human rights. Asia-Pacific governments should build an integrity and capability architecture that makes public health policy resilient, transparent, and locally owned. Regional cooperation should be used to strengthen national systems, not replace national control. When national systems are robust, cooperation becomes a force multiplier rather than a dependency. What does the right to health require in public health policy? A rights-based approach is not only about outcomes, it is also about process. The right to health is widely understood as a duty to take reasonable steps toward prevention, treatment, and the conditions needed for health, using available resources and without discrimination. In practice, this means public health decisions should be lawful, evidence-informed, proportionate to risk, transparent in their reasoning, and accountable through domestic institutions. This is not academic. These processes protect integrity. They reduce the risk of capture, strengthen public trust, and make policy more stable across political change. They also create space for public participation and scrutiny, which are essential to democratic legitimacy. Does regional cooperation weaken public health sovereignty? Regional cooperation, when designed correctly, reinforces sovereignty. Asia-Pacific countries share cross-border health risks, population mobility, and supply chain exposure. Cooperation can reduce costs, close capability gaps, and increase bargaining power. The safeguard is national ownership. Cooperation should be anchored in domestic law, with clear boundaries around decision rights. Domestic institutions must remain responsible for final decisions, enforcement, and accountability. When cooperation builds domestic capability, sovereignty becomes stronger, not weaker. When does external engagement become a sovereignty problem? External engagement is not inherently harmful. It becomes a sovereignty and rights problem when it displaces local priorities, weakens institutional integrity, or creates obligations that cannot be sustained. One common pathway is funding conditionality and agenda setting. External funding may be framed as support, yet it often carries explicit or implicit priorities, preferred partners, and preferred solutions. Over time, this can crowd out locally designed approaches, especially where long-term investment is needed in prevention, regulation, and enforcement systems, rather than short projects that look good on paper but leave little behind. A second pathway is technical gatekeeping. When external actors define what counts as evidence, which indicators matter, and which options are treated as legitimate, domestic policy space can narrow. Over time, the ability to evaluate options and make independent judgments can migrate outward, weakening national capability and reducing genuine policy choice. How do narratives and reputational pressure affect public health decisions? Narrative pressure now shapes public health outcomes as much as technical design. Campaigns can be run through global media, social platforms, and local civil society networks. Ministers and agencies can face reputational threats that push decision-making toward visible actions rather than effective ones, particularly when complex trade-offs are reduced to simple slogans. The result can be policy that is performative and misaligned with local needs. Strong process discipline, transparent reasoning, and domestic accountability are the best protections against narrative-driven decision-making. Can trade and investment settings deter public health regulation? Legal and economic leverage can be applied through trade and investment settings, increasing the perceived cost of regulation and deterring action. The lesson is not to avoid regulation. It is to design regulation that is non-discriminatory, evidence-informed, proportionate, and procedurally fair. Policy built this way is more resilient to challenge and easier to defend, both domestically and internationally. It also signals institutional seriousness, which reduces opportunities for external pressure to distort policy intent. How can governments protect sovereignty while still accepting external support? The goal is not to block external engagement. The goal is to shape the terms of engagement so external inputs strengthen national systems rather than steer them. Implementing tobacco harm reduction in health policy too. 3 practical pillars support this. First, adopt a funding independence rule for core regulatory functions. Where government is setting standards, licensing, enforcing or applying penalties, independence matters. External funds, where accepted, should be pooled and firewalled, so funders cannot shape regulatory decisions. This protects neutrality in rulemaking and enforcement, and it preserves public trust. Second, treat philanthropic and donor engagement like any other government procurement. This requires clear deliverables, local ownership, data ownership terms, publication expectations, and exit plans. If those terms are rejected, the funding is not aligned with sovereignty and should be declined. This approach is not hostile to partnership. It ensures partnership is structured around national interests and long-term capability building. Third, build regional capability so countries can negotiate as a bloc without surrendering national decision rights. Shared regulatory science, lab capacity, reference standards, pooled training for inspectors, and regional procurement mechanisms reduce dependency, lower costs, and increase bargaining power. This kind of cooperation strengthens sovereignty because it expands what countries can do for themselves together. Why is data governance a sovereignty issue in public health? Countries should treat health data as a sovereignty asset. Clear rules are needed on storage, access, de-identification, and external use. Data dependence quickly becomes policy dependence, especially when platforms, analytics, and surveillance infrastructure are externally controlled. When data governance is firm, policy choices remain genuinely national, and external support cannot quietly become external control. Strong data rules also improve accountability, because public institutions retain oversight of how information is collected, interpreted, and used in decisions. What is the practical solution for Asia-Pacific governments? Asia-Pacific does not need to choose between sovereignty and human rights. The right to health supports firm, locally grounded public health action, and sovereignty provides the authority to implement it in ways that reflect local realities. The region's vulnerability is not external engagement itself. It is unmanaged influence and underbuilt capability. The practical answer is to professionalize the policy environment through transparency, conflict management, and capability building, and to use regional cooperation as a strength multiplier. When public health policy is lawful, proportionate, evidence-informed, and locally owned, external pressure becomes easier to absorb, and the region's best interests become harder to override. This is not about closing doors. It is about building systems strong enough to engage openly, confidently, and on their own terms.